what is colla? It's the collagen, okay?
Okay.
So colla 1 and colla 2 gene encodes for the type 1 collagen mostly, okay? Partially type 2, but mainly type 1.
Bone. Okay.
Yeah, which is mostly the bone. So genetic bone disorder, also known as a brittle bone disease. You know what a brittle mean?
Brittle meaning very dehydrated, right, Doc?
Yeah, it's like, you know when you have the shulk board?
Yeah, Doc.
Yeah, so the shulk itself, it's brittle. It's easily broken.
Right.
Yeah?
Right.
So most common form is autosomal dominant with a decreased production of otherwise normal type 1 collagen. So look, you will have reduction of it, and because you have less collagen type 1 was where?
Type 1 is in bone, Doc.
Okay, so the bone will be messed up. I want to remind you that we spoke about osteogenesis imperfecta before. If you remember, we spoke about it in the process of glycosylation. Yeah?
Mm-hmm.
So, in the glycosylation, the sugar was important for one function. I did not tell you yet. Well, when we are speaking about honey, as in sugar, honey is sugar. It's sticky, yes?
Yeah, Doc.
So it helps in making 3 collagens stick into each other, okay? Making a triple helix. Make sense?
Okay, Doc.
So,
Common triple helix. So I guess write down, Doc.
okay.
Got it.
Nice. So the next thing we have here is as follow. Yes, manifestation include multiple fracture and bone deformities. So, okay, so obviously collagen type 1, the bone will be messed up, which means that minimal trauma can lead to bone fracture. Yes? Like,
So, Doc, so all the triple helix formation, I can remember it as being glycosylation, right, Doc?
all types of,
Altered triple helix formation.
yes,
Because
yes,
it is glycosylation where the triple helix is taking place, right?
absolutely. So the formation of triple helix require a bound, okay? And this bound is made by the glycosylated, is it hydroxylysine or hydroxyproline?
It's lysine, Doc.
Absolutely. Nice. Good.
The before one, the hydroxylation has to do something with lysine and proline. This one has to do only with lysine.
And nothing
Right.
with the glycine, correct?
Nothing with glycine.
Which one is the most dominant overall?
Glycine, Doc.
Okay, good. Nice. So that's actually everything they can ask on that page. So,
Doc, 1 second, Doc. So hydroxylation is only lysine, right, Doc?
hydroxylation is only lysine. Hydroxylation, no, it's lysine and the proline. Glycosylation is only hydroxylysine.
Okay, Doc. I'll just 1 second, Doc. Hydroxylation. Okay. And over here, specific proline and lysine. Got it, Doc. Thank you, Doc. Yeah.
So, blue sclera is due to a So these patients tend to have this bluish hue of the sclera. If you look at your arm, you can see your vein under your arm. The vein look bluish, correct? Well, if we open the skin and we take a look at the vein, is it a blue?
No.
It's red, yeah?
Yeah.
So why do you see it as a blue? It's like, because the color, it's some physics stuff, but basically because of the layer of the skin, the color changes, you know? The same idea with our eye. We have something called the sclera. Under the sclera, there is this choroid plexus. Choroid plexus. Let me show you that. I'm sorry. Choroid layer of eye. Choroid layers of the eye. So the choroid layer of the eye is where it is. Yes, it's the middle one. The middle one. So our eye, this ball, is made out of 3 layers, okay? I can't find a decent one. Okay, this is a decent one. Can you see there is the sclera? Under it there is the
Okay.
choroid. And under it there is the retina. Of course, the retina will be to the inside. The sclera and the choroid will be a little bit more to the outside. So which portion of the eye can we see? We
The
only
choroid.
yeah, no, normally we cannot see the choroid. It's the second layer. It's down. Yeah. So normally you can only see this.
Sclera.
Yeah, well, maybe something like this. Yeah.
Yeah, doc.
Okay. So that's mean that you can see some sclera, which is the white stuff in your eye. Yes.
Yeah, doc.
Well, sclera is made out of collagen. So if it becomes thinner, you will be able to see the layer under it, which is the choroid. Okay?
Okay, doc. You said, one second, doc. Just trying to remember this. Cornea is type 1 and lens is type 4, right, doc?
Lens
We
4
didn't.
letters is type 4, yes.
So, what about sclera, doc? Which type is it? Sclera?
1. It must be 1.
1? Okay.
Let's take a look. Sclera,
There's no sclera over here
they
as
don't
well,
mention
right?
it. I see, they don't mention it. But sclera is, it must be type 1. Why? Because it's thinning of the sclera that causes it. Yeah?
Okay, doc.
So, okay, so this is the choroid. This is the sclera. When the sclera is thin, you start to visualize the choroid. Of course, it's not absent, it's just thin. Yes? Okay, makes sense?
Got it, doc.
Okay, so blue sclera, due to the translucent connective tissue over the choroid veins. They do ask this. They do ask the mechanism in which you have the blue sclera. The next one is some forms have tooth abnormalities known as dentinogenesis imperfecta, including abolescent teeth. Do you know what that means? I will tell you.
No, milk teeth, doc? We call it as milk teeth. Is that it?
Yeah, but it's a little bit becomes like a transparent type of teeth. Let me show you. Yes, this one. See, it has a grayish color, and it's a little bit, if you look at the edges, it's kind of transparent. Yeah?
Oh.
Yep, it's like so thin, you are able literally to see the stuff behind it. Yeah?
Okay.
So that's an abolescent teeth. He's weak. Oh yeah, that's a perfect example. Can you see this edges? Abolescent. Yeah.
I know, doc. Yeah.
Yeah, so if you put your finger behind it, you can kind of see it. Yeah? Okay, good. Abolescent teeth.
So this is also type 1 collagen, doc? The whole thing is type 1 collagen, right, doc?
Of course. Yep, all of it is type 1 collagen. Okay, so that wears due to the lack of dentine. Dentine is the one of layers of the tooth, if you remember about it. So the tooth has something called the enamel and something called the dentine. So this is the enamel, which is the outermost portion, and then you have the dentine. So the dentine is to the inside. So if you remove it, you still have some enamel, but so you still have the outer structure, but from the inside it's weak. Yes, which mean it's going to be easily broken. Yes.
Okay, doc.
Yep. Okay, conductive hearing loss. Why? You know this little ossicles in our ear? Middle
Yeah,
ear?
doc.
What the name of them?
Incus stapes malleus.
Okay. So yeah, they will become abnormal because after all they are born type 1 collagen. And the patient is going to get in osteogenesis imperfecta. So hearing loss, yeah? So do you know the function of these bones?
They transmit the sound energy, doc,
Yeah, so
in middle ear.
they condense it actually. They convert the tympanic membrane vibration into the round window vibration, which is smaller than the tympanic membrane in more than 50 times.
30 times, right, doc?
How many times?
30 times, I remember.
Something like that, yeah, but they basically accentuate the sound at this little space.
Yeah, doc.
Okay, so maybe confused with the child abuse. Oh yeah, why? Oh, they bring the baby, they tell you, oh, well, he dropped it from his bed. He's like 2 years. He drops it from his bed and he broke 6 bones. So that story does not fit, you know?
Yeah.
And well, your logic will be like, okay, probably child abuse. But when you see something like this, yeah, which is like all of
Okay.
these curves, can you see the curves?
Yeah, doc.
So when you start seeing curves, you look at the sclera, you see it bluish. You're like, okay, no, this is osteogenesis imperfecta. It's not child abuse. This is why in a step 2 exam, when you have patient with multiple fracture, the answer is not to report to the child protective services yet. The answer is to do a full bone examination. Okay?
Okay, doc.
Yep.
But for this, do we do any genetic studies, though? How do we diagnose this, doc?
Full bone examination, first of all, just to make sure, because, man, you will not do a genetic analysis before doing a full bone examination. It's much cheaper. So if the answer is yes, it might be, you will do the genetic analysis, the actual fish study, we call it fish, and that will tell you for sure he has this or not. Okay? How does it tell us? Because it can check for the cola 1 and the cola 2, okay, inside of the DNA.
Okay.
So treated with bisphosphonate to decrease the risk of fracture. Bisphosphonate is a drug used in osteoporosis as well. Basically, it decreases the osteoclastic function and promote the osteoblastic function, which leads to the bone becoming more stronger. Okay?
Got it.
Okay, so but the bite, the patient cannot bite. Multiple fracture, blue sclera, dentinogenesis imperfecta, and hearing loss. Good? Check. So, can you tell me, please, before I check and go to the next topic, have just a quick question. Can you tell me, I told you I will ask you about this actually, regarding, where was it? Oh yeah. Where is the steroids made inside of our cell? Which organelle make the steroid?
Peroxisomes.
They make cholesterol, not steroid hormone. Let me say steroid hormone. It's made in the smooth endoplasmatic reticulum. Okay?
Okay, doc.
Yeah, that's actually an important point. That's why the adrenal gland, for example, smooth endoplasmatic reticulum is abundant in the adrenal gland. Okay?
Let me just check it out. Steroid. Oh, yeah.
Yep.
So, what about adrenal cortex, doc? What were you saying?
Yeah, I'm saying that in the adrenal cortex, it has abundant or so many smooth endoplasmatic reticulum. Yes?
Okay.
Okay, good. Nice. Okay, done with this. Okay, let's speak about Ehlers-Danlos. So we spoke about cola 1. Now we speak about cola 5 and cola 3. Okay, what about cola? So this is overall is cola 1. Of course, I'm speaking about this one. Okay.
Okay, this is cola 1 and 2, right? Doc? The first one?
Yeah, well, cola 1 with subclass A1, subclass A2. So actually, it is actually genetically, it's like this. COL1, which is collagen 1, subclass A1, subclass A2. Okay?
Okay.
But, yeah, we are still stuck under the collagen type 1. If we speak about collagen 3, A1, A2, it can be something like this. Okay? So,
Okay, doc.
if you take a look here, speaking about Ehlers-Danlos syndrome, first thing to know about this disease. Do you remember a disease that I told you that the patient has in it? self-mutilation. They eat their fingers.
Yeah, dog. Leishman.
Yes, Leishman syndrome. Only 2 diseases in the book have this: Ehlers-Danlos syndrome and the other one you said.
You think which one, dog?
Ehlers-Danlos and oh my God, you just said it. Why it's just slipped away from my brain?
Leishman syndrome, dog?
Leishman and Ehlers-Danlos. Yeah, only these 2 have self-mutilation.
Okay, dog.
Okay. So faulty collagen synthesis lead to hyperextensible skin. Can you see how his skin goes up like this? Yep.
Yeah, dog.
Also,
Dog, why did you talk about cola 3, dog? No, because over here I can see that they say cola 5.
Wait for it. So the
Okay.
Ehlers-Danlos syndrome has two subtypes. Something called the vascular subtype and something called the musculoskeletal subtype. Okay?
Okay.
So the vascular subtype, it's a problem in the collagen type 3. The musculoskeletal subtype, which is the most common, is a problem of collagen type 5. Okay?
Okay, dog.
So the Ehlers-Danlos syndrome, we start with the musculoskeletal. They will have hyperextensible skin, as you can see, hypermobile joint, as you can see. Can you see?
Yes, dog.
Okay. And tendency to bleed. So they can have bruises really, really easy. Okay? So,
Dog, are these the people who work in circus, dog?
yep, absolutely.
Okay.
But to be 100% fair, as a human beings, we can make, if we start doing like some certain movement from childhood, we are able to become a little bit more lean, okay? But if the patient stretch his skin like this is just, no, that's not normal, okay? So, they're right. Multiple types, and inheritance and severity varies. So it can be either autosomal dominant or recessive, may be associated with joint dislocation, peri-aortic or organ rupture. Well, what's up with that? Well, yeah, it has many subtypes, as I said. So some of these subtypes are musculoskeletal, so they can have like joint dislocation. Some of these subtypes can have peri and aortic aneurysm and organ rupture, like uterus, for example. And we'll speak about uterus in a second. So the hypermobility type, the classical type, the vascular type. Let's take a look at it. The hypermobility type is the circus people, okay? So they have joint instability, and most likely they do have what? They have this, they can twist themselves in a weird way. Like they can take their legs, put it on their head. This one is the least associated with complication, okay? So it has the least amount of complication. The second one, it has both the joint and the skin stuff. This one, yeah? See, they can pull their skin like for a distance. I don't know if you ever seen it in real life. They just can pull their skin, yeah, like away from their body. Oh yeah, something like this. And they oh, by the way, be careful, they are not like obese who lost weight or something like that. No, they just can do something like this, okay? Yep.
Okay, doc.
Oh my God.
So, doc, you are saying all this is type 3, doc? This thing?
No, so far we are in the musculoskeletal stuff, so it's type 5 so far. Soon we will reach type 3.
Okay.
Yeah. So soon we will reach the type 3. So the classical type, it's both the joint and the skin. It's caused by a mutation of type 5 collagen as well. It's the COLA5 and COLA5A2. Yes? A1, A2. Okay, what about the vascular type? Vascular type is type 3. It can lead to fragile tissues, including the vessels. Do you remember where collagen type 3 was located?
In a blood vessels, doc.
Yep. So it will affect mainly the blood vessels, like the aorta, muscles, and organs. Which organ? The most common organ to be affected is the uterus. You check the uterus back in the table, you can see that the uterus is which type of collagen? Type 3.
Type 3.
Yep. So the uterus is type 3, thus it can be affected. So This can lead to many cases of abortion. They are pregnant. First trimester, no problem. Second trimester, no problem. Third trimester, rupture of the uterus, the baby dies, and she almost dies. So why? Why it ruptured? Because collagen type 3 is not okay and could not handle a big baby. Yeah?
Yeah.
Okay. So mutation in type 3 broke collagen. Cola 3. Okay?
Okay.
So far you learned cola 1, cola 3, and cola 5. Yes?
Yeah.
Okay. What about cola 2 and cola
It would
4?
have been so good to have vascular type as collagen 5, doc,
Who?
to remember. The vascular type, I wish it was collagen 5
Ah.
because V is like 5, right, doc?
Oh, yeah. Oh,
But
yeah.
it's 3. I was like, shit.
Well, try to make something for it.
And MSK is 3 words and it is 5.
Ah, that's true. That's true. Well, that's true. Okay, well, try to make something out of it. But yeah, you must know the 3
Yeah.
is for vascular and the 5 are for musculoskeletal. So, okay, we spoke all of these collagens. Now something called Minx disease. Sadly, they do ask about the mutation, okay? So, I will give you a trick to memorize it. Anyway, so Minx, what is it? It's an X-linked recessive connective tissue disease. Well, it mostly affects boys. Is there any rare condition in which the woman will have it?
Yeah, doc, when there is a lionization happening.
Of which chromosome, the healthy one or the sick one?
Lionization of the healthy chromosome, right, doc?
Yes, absolutely, good. So, X-linked recessive connective tissue disease caused by an impaired copper absorption and transport due to a defect in the Minx protein. So we will have less copper. Yes? Less copper. Okay, so we are not absorbing copper and we have less copper. So Minx protein ATBA. Oh, so there is the ATB7A and ATB7B. The B is in Wilson and the A is in Minkins. How I memorized it? Well, Minx disease is, we study it in which system? Biochemistry. What about Wilson? GIT. Yes?
Yeah.
So you can see Wilson is in the end of first aid, while Minkins is in the first of first aid. So the first of first aid, that will be A. The end of first aid, that will be B. Okay?
Got it.
Good. So because they tell you ATB7A and ATB7B and they expect you to know it. So in case of Wilson disease, we have a copper buildup, and it can, in case of Minx disease, we have decreased activity of lysyl oxidase. Remember lysyl oxidase?
Is it the last step in collagen synthesis?
Yes, the cross-linking, yeah?
Yeah, doc.
Okay, so the cross-linking will be messed up. All right. It leads to decreased activity of lysyl oxidase. Copper is necessary cofactor for the lysyl oxidase. That's why he's dysfunctional. And the lysyl oxidase, it helps to make basically the cross-linking between the collagens to make an actual collagen. So that will lead, if it's absent, we will have a defect collagen. The result is a brittle, kinky hair. You know, like the black population tend to have this hair that is like this, spiral. Yeah?
Yeah, doc.
Kinky. So that's kinky hair. And the growth and developmental delay. Okay.
Got it.
And also hypotonia. Okay. So why is this disease serious? Because these poor patients can have this. This is the only important thing. Increased risk of cerebral aneurysm. So which type of hemorrhage inside of the brain they will have?
If it's aneurysm, then hemorrhagic stroke, right?
Yeah, is it epidural, subdural, or subarachnoid?
This is a subarachnoid, doc.
Yes, always subarachnoid. And you must know how it looks like, okay? Because this is how they ask the question. They do tell you the story. they do show you a subarachnoid hemorrhage, and they do ask you about the gene. So if you take a look, in case of subarachnoid hemorrhage, the blood is within the cisterine of the brain. What is the cisterine? The spaces between the gyri. Yes?
Okay, doc.
Mm-hmm. Done. Okay, next one. Elastin.
Doctor, one second, doc.
Uh-huh.
Can you once again explain this cross-linking part, doc? So, this cross-linking is done by lysyl oxidase.
Uh-huh.
But what's the role of copper in here, doc? What's copper doing here?
It's a cofactor. You know what is a cofactor?
Okay, it's a cofactor which requires for the cross-linking to happen.
It's a cofactor for the lysyl oxidase, yes.
Okay.
Yep.
Okay.
Okay.
No break, doc?
It's up to
Page
you.
over?
We did not do much. We just did 30 minutes. So
Okay, I thought every page is a break. Okay.
Well, actually, yeah. Okay, 5 minutes. Only 5. But
Okay.
be back in 5, I'm telling you. Nice. Let's continue. So the next thing is about elastin. What I want you to know about elastin, it's like a rubber band. You know what is a rubber band? It's like this thing that stretches.
Yes, doc.
Okay, good. So the rubber band, it's like the main idea of it, that it can stretch and you can relax it back. Yes?
Yeah, doc.
So let's just forget about this page. Let's just speak about a little bit about rubber bands. So rubber bands can stretch and relax. Stretch, relax. Okay, but I want you to know one thing. In our body, the rubber bands are weird. They like to stretch, not to relax. Normally, the rubber band like to relax, not to stretch, yeah? But in our body, they like to stretch. So they always want to stretch like this. But what prevents them from stretching too much? The answer is something that we call a scaffold. You know what is a scaffold?
No, doc.
It's for buildings. Scaffold. This thing. Yep. Do you know what that is? It's like when you build a building, you put this on the outside to build the building, and then you remove it. Yeah? So it's around the building.
Okay, doc.
Yep. So yeah, the scaffold is put in around the building to maintain it during the time of maintenance. Yep. I remember them from my previous life when I used to work with these. Oh yeah. So
Okay.
good. So the scaffold, sorry, the color. The scaffold goes around the elastin, okay? And it helps to keep it in place. If you don't have the scaffold, what is going to happen to the elastin? It's going to stretch, okay?
Yeah.
If you have the scaffold, perfecto, no stretching, okay? So now comes the question, what is the scaffold in our body? The scaffold in our body is called fibrilline, okay? Fibrilline.
Okay.
Good. So now everything will make sense. So we have elastin. It can stretch or relax. When it's stretched, it becomes longer. Yeah? So it's a stretchy protein within the skin, the lung, the large artery, elastic ligaments, and even vocal cord. And even the epiglottis, ligamentum flavum. You know what that is?
No, ligamentum flavum. No.
So ligamentum flavum is a ligament inside of our spinal cord canal. Okay? Ligamentum flavum. And it's one of these guys that you must penetrate during like a lumbar puncture. You know? So, can you see it? It's this one. So when you come with a lumbar puncture, you must penetrate him. Yes?
Okay.
And why we call him a flavum? Because he's yellow. And the color yellow, in Latin, we say flavum. Okay?
Okay.
Good. So far, so good. In the future, I will be telling you, during lumbar puncture, which ligaments do we burst? You have to tell me it's ligamentum flavum. Okay?
Okay.
Okay, good. So next. So yeah, it connects the vertebra, and it's relaxed. It has like a relaxed and stretch conformation as well. Okay, what I want you to know from the elastin so far, what is it made out of? Remember what collagen was made out of?
Type 1 to 5, right?
Yeah, but well, I mean, they were made from which amino acid?
From glycine, proline, and lysine, doc.
Excellent. Were they like hydroxylated or non-hydroxylated, the end product?
Everything was hydroxylated, right? Doc?
Good. The end product, of course. Yeah?
Yeah.
Okay, good. Because the elastin, it's a non-hydroxylated proline, glycine, and lysine. Okay?
Okay.
Versus hydroxylated in cases of collagen. Make sense?
Rich in non-hydroxylated collagen, lysine, and
So
lysine.
when we spoke about collagen, we said, oh, we hydroxylate the lysine and the proline. But now it's in the elastin. They are not hydroxylated. Yeah?
Okay, doc.
Okay. So tropoelastin with fibrilline scaffolding. I hope you understood this. Is this thing that I spoke about? Yeah?
Yeah, doc.
Okay. So the cross-linking, you remember what is a cross-linking? In case of collagen, it was mediated by which enzyme?
The lysase, doc.
Lysyl oxidase, which has which cofactor?
Lysyl oxidase. Copper.
Okay, and copper was deficient in which case?
Minkies, doc.
And Minx has which type of hair?
They have those thin curvy hair, right? Doc? Kinky hair. Okay.
Kinky. I like the word kinky. So
Kinky.
Cross-linking takes place extracellularly and give elastin its elastic properties. Okay, so broken down by something called elastase. Okay.
Doc, isn't cross-linking same as for collagen, doc? That also has the same thing, right?
Absolutely the exact same thing. Actually, elastin and collagen are so similar, but they just have a few differences. For example, this
The
one,
hydroxylation.
yeah, the hydroxylation thing, for example. That's one thing. Collagen, for example, did not have a scaffold. This one has a scaffold, okay?
Got it.
So it's broken down by elastase. Well, elastin is broken down by elastase, which is normally inhibited by alpha-1 antitrypsin enzyme. So there is something called alpha-1 antitrypsin. This guy is produced in the liver, okay? And it's a protease. Good? It's a protease. Protease inhibit elastase, yeah? It inhibits elastase. And elastase normally break down what? Elastin, yeah?
Okay, doc.
Normally. So let's say somebody has like liver dysfunction, yes? Sorry, he has an alpha-1 antitrypsin deficiency. Okay, no antitrypsin 1, no proteases. What happens to the elastase now?
Goes up.
Goes up. What happens to the elastin?
Comes down, doc.
Comes down. Elastin makes the septi of the alveoli. So what happens to the septi of the alveoli?
No compliance, right, doc? It's not able to
Yeah, not
expand.
formed. Not formed. Yes? So,
Okay, yeah.
well, if that is the case, it leads to a disease called emphysema. Okay? Notice, in emphysema, the walls of the septi made out of elastin are no more. Yeah?
Okay.
Because this is normal, this is our case. Make sense?
So, doc, in emphysema, it's not able to stretch, or is it not able to recoil, doc?
Again?
In emphysema, the alveoli, are they not able to recoil, or are they not able to stretch?
Are they not able to recoil? They are not able to recoil. Come back recoil, you mean, yeah? Like a close back.
Yeah, no.
Yeah, they
Yeah.
are not able to do that. Yes. Because, why I know this? Because it's an expiratory dysfunction, okay? It's an expiration dysfunction. not an inspiration dysfunction. We even say COPD. It's an obstructive disorder. All of the COPDs are a problem of getting air out. Okay?
Okay, doc.
Yep.
So, one second, doc. You're saying alpha 1 trypsin is a protease, right? And protease inhibits elastase. Is that right, doc?
Correct.
So, I'll just write it down, doc. 1 second. No place to write down.
It's a really interesting topic because we will be speaking about it twice. Once in GIT, and the other one is going to be in like lung.
Okay, doc.
Good.
So protease inhibits. 1 second, doc. I'm trying to write it down in a nice way.
Mm-hmm.
So you're saying protease inhibits elastase.
Yes. Well, protease is the same thing as saying alpha 1 antitrypsin.
Yeah. And elastase inhibits elastin.
Yep.
So this is alpha 1 antitrypsin. So in this deficiency, we'll have more elastase. Will have more elastase, right, doc? In alpha 1 antitrypsin deficiency. So more elastase meaning less elastin.
More elastase, less elastin. Yes.
Okay. So in alpha 1 trypsin deficiency, we have less elastin.
Correct. Less elastin, not elastase. Elastase is high.
Got it.
Good.
So that's for COPD.
Yep. So alpha 1 antitrypsin deficiency released lead to unopposed elastase activity, which causes COPD. Make sense?
Yeah, doc. But were you talking about emphysema then, doc, the COPD?
Yes, it's an emphysema is one of the types of COPD. Remember, we also have chronic bronchitis under COPD.
Okay, doc.
Yep.
We should do respiratory next, I guess, after GI.
Okay. Respiratory is a really short chapter, actually. Really short chapter. So,
Okay.
changes with aging. So, yeah, this is normal change with age. For example, they have decreased dermal collagen and elastin. Yeah? If you look at an old person, you can see that their skin is a little bit like, if you take it, I cannot describe this. If you pull it and let it go, it takes a lot of time to go back. Yes?
Yeah, doc.
So why? Because the recall is messed up, because their elastin is low. Yes?
Got it, doc.
One more thing. If you try to do an IV on an old person versus a young person, which person is more difficult to do the IV
on? Maybe young person, though?
Actually, the old. Why? The young have a well-developed subcutaneous fat around the vessel, so the vessel is just sitting in the place, So if this is the skin, this is the vessel, there is a lot of fat here and like collagen and stuff, so the vessel is in the place. In an old person, it's like this. So you want to put the needle, but this thing keep dancing around, So it's like you hit it and it moves. It should not move. So how to deal with it? Press too strong on it, keep it in place, and just push the needle in. Yep.
Okay. This is problem with the scaphoid protein, right, doc? The fibrilline, that's it.
Yeah.
So it is very stretchy because of that.
The what? The vessel? No, man. It's just like the vessel is here and around it.
No. I'm not talking about this thing, doc. Just in general. Just in general, whenever there is a problem with fibrilline, it stretches more. You're saying, right, doc?
Absolutely. Yes. And which disease has a fibrilline defect?
Marfan's.
Yes. So let's speak about Marfan. In Marfan syndrome, it's an autosomal dominant disease with variable expression. What does variable expressivity mean?
The severity depends on how, it depends, though.
Yeah,
depends on how it's expressed.
Absolutely. So there is different types of severity in the patient. Okay, it's a connective tissue disorder affecting the skeleton, the heart, the eyes. And we will understand why. It's a defect in the FBN1 gene, which is the fibrilline gene, and mutation on a chromosome, again, one more F, Marfan F15, resulting in defect in the fibrilline 1. Okay, fibrilline 1, no fibrilline anymore. We don't need your fibrilline. So the elastin, what will happen to it?
It's going to expand now.
Okay, good. So a glycoprotein that forms a sheath around an elastin and sequesters TGF beta. So far, I want you to know about the sheath around the elastin, okay? The idea of keeping and sequestering the TGF beta will be important in a second, but for now, forget about it, okay?
Okay.
So finding will have are tall, the patient will be really tall with long extremities, okay? So they will have like really long extremities. Why? Because the elastin is uncontrolled, yes?
Yeah.
Also, they have this chest deformity, which is something called the pigeon chest. Do you know? Yeah, okay, good. Or the bis excavatum. So they have this cave inside of their chest, or it can be to the outside. Basically, dysfunction of the elastin is going to lead to that. Well, the elastin is still the elastin, but it's because it's not scaffolded anymore. Yes? Also, the joint can be hypermobile. We also spoke about it in which disease?
Hypermobile joint is in LS.
Okay. Long tapering finger and toes. That we call arachnodactyly. What does the word arachno mean? Arachnodactyly, it's like arachno. You know Spider-Man? Spider.
Spider, yeah. No.
So a spindle finger, like the fingers of a spider. What about subarachnoid hemorrhage? Yeah, because the the arachnoid membrane is a spider web-like structure. That's why we call it the arachnoid, okay?
Okay.
So cystic medial necrosis of the aorta, this is an important thing. This is because of the TGF problem, okay?
Okay.
And because of the medial cystic necrosis of the aorta, the patient can get an actual aneurysm. And you will tell me, if I have an aneurysm of my aorta, which valve will be involved?
Aneurysm of aorta will be an aortic valve involved.
Which problem it will have?
Aortic regurg.
Why?
Because annulus is expanded, so the valve is not able to close properly. There will be gaps.
Excellent. Good. So the patient is either going to get an aneurysm or dissection. What is dissection?
Dissection is forming a layer between the intima and media, though?
Correct. Good. So mitral valve prolapse. Think about it. Why such thing might happen? The answer is, do you remember the chorda tendini?
Yeah, though. It becomes long.
Absolutely. So the valve will be parachuting into the left atrium. Yeah?
Yeah, though. Yeah.
Also, they have increased risk of spontaneous pneumothorax. If the question is why, it's because of formation of something called the pleural blip. You know what that is?
No.
Pleural. Okay, pleural blip is something like this. Can you see this? It's just an little out pouch, and it just might burst. So it can lead to spontaneous pneumothorax. Yeah?
So, doc, pneumothorax is fluid, doc?
No, pneumo air. Okay? Air.
What is fluid, doc? What is it called? Pneumothorax?
Hydrothorax. Or hemothorax if it was blood. Yeah?
Okay, doc. Okay.
Where are you, Sushan? Here you are.
Okay.
Nice. Good. So, finding include tall with long extremities, chest wall deformity, we spoke about this, hypermobile joint, we spoke about all of this. Okay, done. So spontaneous pneumothorax, it's spontaneous when it occurs from the lung. It's traumatic when it occurs from the chest wall. Okay?
Because of blebs, right, Doc?
So spontaneous because of the bleb. Traumatic is because like a stab or something like that from the outside. Okay?
Got it. So, Doc, is cystic medial necrosis same as cystic medial degeneration?
Absolutely.
Because we saw it in cardiology, right, Doc, during the abdominal and aortic aneurysms?
Absolutely correct, yes. And it's mediated by the TGF beta, yes.
And it's mediated by TGF beta. So, do you ask me to forget it? That's the only point, Doc?
Yes, I told you to forget about it then, because you will be like, what is its relationship with hypermobile joint? It does not have any relationship. It only has a relationship with the cystic medial necrosis of the aorta. That's it.
Okay. 1 second, Doc. I need to note. Mediates cystic medial necrosis. That's it, right, Doc?
Yep.
Okay.
Okay, so Marfan is autosomal dominant, correct?
Got it, yeah.
What about the mental function of these people? Are they smart or stupid?
They're regular, I think, no?
Normal people, yeah?
Yeah.
Okay, so they can have also this aortic aneurysm or dissection, correct?
Yeah, Doc.
And the most important thing, like more than anything I said so far, is the lens dislocation, okay?
Okay.
So what does it mean, lens dislocation? Any idea?
Yeah.
So because the zonulae which hold the lens becomes taller, the lens will be dislocated. Can you see?
Got it. Yeah.
Yeah. So there is two types of dislocation. It's either up and out or in and down. Okay?
Yeah, no. In and down is Hemosystenoria.
Yes.
Up and out is Marfan's.
Absolutely. Good. So Hemosystenoria, we will have a presentation similar to Marfan syndrome with pectus deformities and tall stature, increased arm to height ratio. Hemosystenoria, the most important complication of it, surprisingly, it's not written. It's actually that they have a hypercoagulable state. Okay? Why? Because the homocysteine actually start working to damage the endothelial cells. Okay? The damage of the endothelial cells promote one of three things in the Verkov triad. You know what is Verkov triad?
No.
Verkov triad include the three things which can lead to hypercoagulability. Endothelial damage, that's one. Hypercoagulable state, that's two. And stasis, that's three. Okay?
Okay.
It's the three things that can lead to thrombosis. So, hemocystinoria presentation similar to Marfan with the pectus deformity. Basically, the musculoskeletal stuff are the same. Tall stature, long arms to height ratio, but their legs are going to be even taller. Okay? So their arms are long, but their legs are even longer. Okay? So these patients are like this, and that's their hand. But their legs is like this.
Got it.
So their hands to their body size is ridiculously big, but their legs compared to their hand is ridiculously big. Okay?
So, Doc, what's the problem in Hemosystenoria? But like in Marfan's, we know it's Fibrilline.
It's an autosomal recessive disease, basically multiple genes involved in it. Thus, thanks God, we don't have to know exactly the problem.
Okay, Doc. And Doc, what's the difference between Marfan's and Hemosystenoria, like other than the lens?
So the lens and the vascular stuff. So in hemocystinoria, here it is. The thrombosis will be, yes? In Marfan, it's going to be the aortic dilatation and dissection. Such thing cannot occur in hemocystinoria. Okay, so inheritance, dominant recessive, intellect normal decreased, vascular complication. They have aortic root dilatation, which can lead to aortic regurg. What is the sound of aortic regurg?
Aortic regurg is blowing murmur, decrescendo murmur.
Good. And hemosystenoria, it will lead to thrombosis. Lens dislocation in case of Marfan will be up and out. Hemosystenoria will be downward. All make sense?
So, Doc, if I see someone with hemosystenoria or Marfan's outside, like generally in general public, how do I know he's hemosystenoria and he's Marfan's, Doc? Because they almost have the same thing, right? Doc, pectus deformity, their tall stature and their arm to leg ratio is high.
Look at their eyes.
Just the eyes? Just the eyes is the thing which differentiates them?
Yes, absolutely. So you look at their eyes and you can take a look. So, for example, this one is a subluxation. Which type of subluxation is it? This one?
That's up and out, Doc.
Okay, that's it.
So Marfan's.
Yes. So you can take a look at their eyes and you can determine. You know?
Okay. Can you show me hemosystenoria, Doc?
Let me take a look. This guy. Can you see it? It's down. Going down.
Okay.
Yes, this guy as well. Down. Of course, the lens dislocation must be not due to a trauma. Okay? Because
I think I was doing a question the other way, Doc. I think it's something to do with cross-linking. Sweet peas. They said that it inhibits lysyl oxidase, which is used for cross-linking, right, Doc?
Yeah, we spoke about it. But what is this sweet peas?
Sweet peas, they say actually, I think the question had that they were giving sweet peas to a rabbit. And it contains beta amino propanyl nitrate. Beta amino propanyl nitrate, and that inhibits lysyl oxidase. And that's why they'll have cross-linking problems.
Nice. So they ask you about like Minx disease indirectly, yeah? So they told you some experimental stuff, and lysyl oxidase is inhibited. You knew that it was Minx, and according to that, you needed to act according to Minx disease. So the patient is going to have a cross-linking dysfunction, thus poor collagen, thus subarachnoid hemorrhage, and these stuff.
I think they were talking about cystic medial necrosis, though.
I
Something
see.
like that.
I see. Okay, so this
so many associations. Yeah.
You know why they are doing this these days? Because Ambos is following them. They are trying to make the bull really big, so nobody have time for Ambos. Oh my God.
Oh.
Okay.
You want to take it, Doc, and start in 5 minutes?
Actually, a little bit more because I have to go have lunch with my family. Okay.
Oh, okay. Did you tell them now?
About what? Oh, not yet.
About them.
Not yet.
I thought you were going to say it last night, Doc.
I wanted to do that, but my father was asleep, so I was like, okay, tomorrow.
Okay, man. Great.
So, see you.
Yeah, Doc.
Bye-bye.